time given, sir. But
1
then
minute. Okay.
Depends upon you, sir.
Okay, it can be a couple of minutes. Like
Doctor, we are live now.
Okay.
Yeah,
excuse me, doctor, we are live now.
Okay, sir. Thank you. Very good afternoon, respected seniors, teachers, colleagues, friends, and the presenters. Wishing you all the best for your presentation in this session. I request Dr. Rajashekar sir to moderate the session. He's the professor in RIO, GOH, and he's a retina and UVA consultant. More than all, he's an excellent teacher. Have had an opportunity to attend his classes on diffraction and other stuff. He's an excellent teacher. I welcome you, sir, to moderate the session and introduce our judges to the session.
Yeah, thanks, Dr. Priya. I think we should thank everybody from TNOA, the president, the secretary, the office bearers of MCOA, and the scientific committee chairman for giving us this excellent opportunity. It's a August gathering here. Dr. VR Vijayaraghavan sir needs no introduction. He's the teacher of all teachers. He's the teacher of all teachers, and his teaching is one thing that inspired us through our life and career. Dr. Sundar sir, he's the most mature and most respected professor of ophthalmology, and his words and his sessions are like, in my opinion, a delight to watch. Dr. Stephen is an alumni of RIO and presently is the professor at Chettinad Medical College. And between us, we are going to see the sessions on comprehensive ophthalmology and neuro-ophthalmology that's going to be presented by youngsters. I, in fact, wish the idea that though we cancelled the conference, we adapted to the request of these young students because they are going to finish their course and leave the student career and become consultants. So this idea of having a free paper session, I, as a voice of all in our session, think that we should hugely congratulate the TNOA and the MCOA and the organizing committee of this session. Without wasting much time, we'll start on with the sessions. We can call the first student. I should remind the judges that they should also open their Google spreadsheet on a separate cell phone and like be able to enter it as they.
Sir, we can enter it at the end, no, sir?
Yeah, sir. Yeah, your wish, sir. Then you make a small piece of paper. You make the markings.
Okay.
Cell open பண்ணிட்டு அப்படி தட்டிட்டு போ.
Okay, sir.
Panninganalo, it is dynamic, sir. They will help you.
Okay.
Paper 22 வரதா.
Yeah. Student number 22. I'll just open page 1.
Paper 22.
Dr. Rita Hepsi Rani. Dr. Rita Hepsi
Yes,
Rani.
sir. I'm ready, sir.
Yeah. Please. The session is yours. You can start sharing your screen.
Okay, sir.
Once you share the screen and start slideshow, we'll switch on the timer.
Shall I start, sir?
Yeah, please.
Good afternoon to all of you. The number is FP288. Topic is lag of ophthalmos and etiological outlook to frame the decision for management. The aim of the study is to analyze the prevalence of different etiological causes for lag of ophthalmos and to study the outcome of medical and surgical management. Methodology was conducted at tertiary level hospital from January to December 2019. This is prospective intervention study, and patients presenting with lag of ophthalmos were examined, and ophthalmic and neurological evaluations were done. CT brain was advised to patient presenting with neurological deficit. 100 subjects were taken for study. In inclusion criteria, all the patients presenting with lag of ophthalmos. Exclusion criteria is nocturnal and physiological lag of ophthalmos and flappy eyelid syndrome. Etiological aspects. The etiological spectrum was broadly classified into paralytic and mechanical causes. 86% were paralytic and 14% were mechanical causes. This is similar to the study by Ador KK from et al. Study. The paralytic causes are trauma, CVA, Bell's palsy, tumor, infections, iatrogenic, congenital and following injection botox. The mechanical causes include cicatrization, eyelid surgery, proptosis, and congenital eyelid causes like coloboma. So here 86% paralytic causes, out of paralytic 44% is Bell's palsy. And observation, a thorough history causing lag of thymus was elucidated and ocular examinations were done, and patient's treatment of strategies based on the presence or absence of exposure keratitis, and exposure keratitis graded as 1, no corneal involvement, 2, punctate epithelial erosion involving lower third of cornea, and 3 is involving more than 1/3 cornea. And 44% of the patients developed exposure keratitis in our study. And management of lag of thymus first and foremost involves the patient's education, and a multidisciplinary team approach is required. Based on the etiology, the disease is categorized as resolving or non-resolving condition. Facial palsy following infection, Bell's palsy, CVA, and post-Botox injection usually resolves over time. This category of patients usually respond to conservative measures such as topical antibiotics with lubricants, eyelid taping, eyelid hygiene, and physiotherapy. But a case of exclusion falling in this category is leprosy infection with a severe lag of thymus, require lateral torsal strip along with tarsography. Facial palsy resulting from tumors, parotid and facial-maxillary surgery, eyelid causes like cicatrization, ptosis require surgical causes. Need for surgical intervention. The persistent exposure keratitis and non-resolving facial palsy, majority of eyelid causes needed surgical correction in the form of lateral torsography. The functional outcome and resolution of exposure keratitis with improvement of visual acuity was noted. Patients developing facial palsy following tumor resection, maxillary
1
procedures,
minute to go.
radiotherapy following failed torsography, they recur additional surgeries like maxillary reconstruction with maxillary fillers. Cicatrical eyelid causes recur eyelid reconstruction procedures. Congenital upper lid coloboma, reconstruction with the tensile semicircle flap done, and overkeratosis needed LPS advancement surgery. This is a clinical picture, the eyelid opening and after closing the eyelids. The results were major cause of lag of thymus is due to idiopathic Bell's palsy. The following observation shows that the presence of exposure keratitis is less among those cases. The patient who had exposure keratitis among this subset also showed good response with the medical management. Among the paralytic causes, those which occurred due to tumor and infection involved parotid and facial regions require surgical intervention, whereas the spectrum of eyelid causes, most persons needed surgical intervention. And this is a patient with post-lid reconstruction. And conclusion of the study is early diagnosis and management lead to prevention and early recovery of complications and better visual proof. Thank you.
It's a Hepsi. Can you show your face?
Yes, sir.
Face video on.
Yeah. Yes, sir. Yes. Sir, good afternoon, sir.
See, when you press a level,
Sir, not audible, sir.
Sir, any questions? Any questions to Dr. Rita? Sundar sir.
Rita, yes,
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 sir.
sir. Why that you have excluded nocturnal lag of thymus? Any reason is there?
Sir, most of the time it heals by medical management, sir. I didn't see a case. We didn't come across such a cases, sir.
Okay, okay. Since it's a multidisciplinary hospital,
Yes, sir.
in ICU, ventilated patient, comatose patients, that and all can be included, no?
Yes, sir.
Because that is the only thing we can prevent easily, that exposure. And that numbers also, major numbers are there in ICU, ventilated patients and all. More exposure is there, no?
Yes, sir.
Yeah. Otherwise, your presentation is good.
Thank you, sir.
Okay.
Okay. Okay.
Dr. Rita,
Yes, sir.
you told all the cases are Bell's, most of them are Bell's palsy, no?
Yes, sir.
So what was your, how do you confirm it was a Bell's palsy? Whether it is other herpes zoster infection like...
So
Or
nothing
how
is there, sir. Yeah, without any etiology, sir.
So you diagnose it by exclusion?
Yeah, exclusion. They every opinion obtained. Then finally, they referred to here, sir.
So
No other causes. Yes, sir.
You got a second opinion with other ENT?
Yeah,
and other
ENT
people?
department and neurology department opinion obtained, sir.
So everybody agreed to it's Bell's palsy, then you
Yeah.
put it under Bell's palsy.
Yes,
So
sir.
most of them were given antivirals?
No, antiviral is not given, sir. Simply prednisolone tablet and physiotherapy, facial stimulation exercise given for 10 days, sir. And we'll advise for massage.
The tumor you told, no? Is it a parotid tumor only or even brain tumors? Any brain tumor was there causing lack of thalmus?
Yeah,
Or only the
one
parotid
case,
tumors?
yeah, CT, the temporal lobe tumor, one case, sir. One case of CP angle tumor, and 2 cases with post-maxillectomy, squamous cell carcinoma of maxilla, after maxillectomy with a severe lag of thalmus, they came, sir. So
see, your study is only about isolated facial nerve palsy, not combined 5, 6, 7. It's only isolated facial nerve palsy.
Yes, sir.
Is it?
Yes, sir.
Yeah.
No, sir. One case with the Gradniger syndrome presented with the facial palsy, sir. That case is also included, sir.
Included. So most of the cases are isolated facial palsy.
Yes, sir.
1 or 2 may be included with other cranial
Yes,
nerves,
sir.
Gandanigo.
Yes, sir.
Okay.
Thank you, doctor. Thank you.
Thank you.
It's a nice
Thank you, sir.
presentation. Can I call Dr. Nivetha? Dr. Nivetha, FP288.
Hello, sir.
Yeah.
Is my slides visible, sir?
Yeah, yes, you can start,
Shall I,
doctor.
shall I start, sir? Okay, sir.
Yeah, please.
My topic is firecracker injury in a tertiary eye care center, a case series. Fireworks related ocular injury is an important cause of preventable blindness worldwide. So it is more in India. It is more common during Diwali, the festival of lights. So here, children are more susceptible than others due to lack of parental supervision and close distance to firework. Objectives of the study is to analyze the ocular presentation of firecracker injury in a tertiary eye care center and to highlight the importance of firecracker injury resulting in significant morbidity. Materials and methods. It is a hospital-based single-center retrospective case series in which 208 patients who attended the emergency eye care services in a tertiary eye care hospital during Deepavali festival in 3 years were analyzed, and these patients were underwent a detailed ocular examination, and these patients were classified according to Birmingham Eye Trauma Terminology System as open globe and closed globe injury. My results. Age of the study patients ranged between 3 and 72 years. Majority of the patients involved are less than 20 years of age, accounting for 60.1%. Mean age was 14 years. Males are more commonly injured than female. 66 patients were actively involved in lighting the firecracker, and 142 were bystander or passerby. At initial presentation, the visual acuity of 4 patients aged less than 5 years could not be assessed. Most common cause of ocular injuries were flower parts, bombs, and sparkles. This is a table showing the type of injury. Here, the corneal aberration is the maximum, then followed by hyphema and subconjunctival hemorrhage, and the least being the globe rupture. Then, according to Birmingham Eye Trauma Terminology System, 84.6 patients were closed globe injury, 5.8% had open globe injury, and 9.6 patients had lid injury. The same thing with contusion being the maximum, 164 patients. Age distribution. Majority of the patients are ranged between 3 to 20 years of age, then followed by 21 to 40 years. Visual acuity at the time of presentation. Most common it is around 560 to 160. No PL is 3 patient. It is due to 3 patients had globe rupture. Most of the patients with the closed globe injury had a good visual improvement of more than 2 lines by Snellens during follow-up. Patient with the open globe injury with visual acuity less than 160 and who underwent surgery. Only the globe integrity was able to achieve, but the visual acuity was not able to improve, resulting in significant ocular morbidity. These are some of the pictures at the time of presentation. Treatment. Patient with superficial minor injuries are treated with topical cycloplegics, antibiotics, steroids, and lubricant drops. Oral acetazolamide are added for hyphema cases. These patients are followed up on next day on day 3 and 1 week interval. Open globe injuries like conjunctival tear and corneal tear are sutured with 10-0 nylon and globe rupture with 8-0 nylon. Lacerations with lead injury were sutured in layer. Amniotic membrane graft are done for large epithelial defect. And during these patients are followed up for the occurrence of cataract, secondary glaucoma, vitreous hemorrhage, retinal detachment, and optic nerve injury. Discussion. Most common age group affected were less than 20 years of age, mean age group being 14 years. This is because children are more curious than young adults, and and because of the risk-taking behavior. Onlookers are frequently affected because of the practice of lighting firecrackers in streets and relative inattentiveness of the bystander compared to the active participants. Our study also showed a male preponderance similar to the other studies. Our study showed injuries ranging from lid burns to globe rupture. Poor visual
1
outcome
minute
was
to
seen to
go.
be associated with poor initial vision, brain-hitting injury, and globe rupture cases. The unanticipated explosion due to malfunctioning devices or misuse of the device were responsible for inflicting these injury. The limitations of the study include the retrospective nature and single center, and mainly the ocular and lid injuries were alone included. So, a multi-center study of firecracker injury burst, if carried out, may provide a better overview of the spectrum of this public health problem. In conclusion, Fireworks cause serious preventable ocular burns and related injury, particularly in children. So, health education, public awareness, and tighter legislation are essential. And restricting the fireworks to public open spaces, regulating the quality of fireworks, and promoting safe use in schools, websites, and other social medias can also be done to create public awareness and thereby reducing the ocular morbidity. These are my references. Thank you.
Injured.
Nivetha, have you removed all the foreign
Sir?
bodies in the cornea? You have got no firecracker injuries.
Yes, sir.
Had any foreign bodies in the
Yes, sir.
cornea?
Yes, sir. After giving thorough saline wash and removing of the soot particles.
Did you remove all the foreign bodies in a single setting, or multiple foreign bodies are there? What did you do? You did what?
Sir, in multiple settings we removed it, sir.
Multiple
Initially,
settings. Yes.
Initially the superficial foreign bodies were removed, sir. And if it is little bit deeper, we removed it in the next setting, sir. We asked the patient to come on. We started on antibiotic and topical lubricant and all. And we asked the patient to review on the next day also. Then that day also we removed the other soot particles, sir.
So IFEMA was there, and that time any
Yes,
rupture of the sclera and all is there. Have you ever noticed any rupture of sclera?
Rupture of the sclera in hyphema cases was not there, sir.
Did you take intraocular pressure for all the patients died?
Yes, sir. Yes, sir. We took the initial at the time of initial presentation. We took intraocular pressure using eye cat tonometer, sir.
You can put pressure over the eye.
Yes, sir.
Normally we expect, suppose you suspect rupture or something, never do indentation tonometer, whatever things in. You should not put any weight on the eye because the problem will increase.
We didn't.
இவங்க rebound use பண்ணிருக்காங்க sir. Rebound.
Sir, eye cat tonometer only we used, sir.
Yeah.
Okay, sir.
Sundar sir.
Yes, sir. It's a nice presentation, sir. No,
nice.
No question.
I think it will be more nice if they can do a follow-up. All children paranga, so they can do a follow-up of 6 months and see what happened to their cohort after 6 months.
Okay,
Doctor,
sir.
please extend the study and make it like prospective into 6 months or 1 year down the line, and see how many of these patients went in for like irreversible visual loss, thisis bulbi, or some infection or something, and how many people recovered. And I'm sure some of them will have glaucoma, some angle recession, some glaucoma. Probably down the line only you'll notice. In this study might be you'll not be able to pick up that. So that's one suggestion we'll give. So please do that. Stephen?
Yeah, Dr. Nivetha, one more doubt.
Yes, sir.
So in your case, it's a blunt injury is a culprit, or it's a thermal injury is the main culprit?
Sir?
For causing ocular injury. Is it a blunt injury or mechanical injury or the thermal injury? Blunt penetrating or thermal, which was causing more damage to the patient?
Sir, blunt injury and thermal injury, sir.
No, blunt. No. Mechanical injury can be
mainly blunt.
And that blunt injury was due to cracker itself, or the stone or something in the ground, which is the most important thing. Or the cracker particles causing blunt injury, or the stones, or any plastic which is in the road which got blast and then come and it as a pellet. So which is can you identified it and asked about it?
Stones are most commonly injured, sir. Compared to the firecrackers, the stones on the roads that fall on the eye, no, sir. So that caused these kind of penetrating injuries and all, sir. Very
good. So if you include that as an important point in firecracker injuries, the stones. Okay, so don't light the firecrackers where there is much of any other debris other than crackers, like stones or any plastic particle is there. This may cause more damage to the bystanders. So light a cracker in a place where it is clean or there is devoid of stones or any sharp objects. So that point you can add so that it will prevent the damage, because most of the damage was due to stones, not due to crackers as such.
Yeah.
So if you can add that, it will be better.
Yeah.
Okay,
nice.
Sir.
Nice.
Thank you, sir.
Thank you, doctor. Thank you.
Thank you, sir.
Can I call now Dr. Durga, Naga, Sushmitha, Jasti, FP287. Dr. Durga, are you here?
Yes, sir.
Yeah, please start sharing your screen.
Am I audible, sir? Can you see my slides?
Yeah. Yes, please. You can start.
Good afternoon. I'm Dr. Sushmitha, final year MS resident. I would like to thank Dr. Kausalya ma'am for giving me this opportunity. My topic of presentation is pale disc in pediatric patients, a clinical review. Coming to the introduction part, there can be different causes of optic atrophy. Some of them are hypoxic ischemic encephalopathy, tumors, hydrocephalus, infections, inflammation, trauma, congenital, hereditary, idiopathic. And there has been an emerging trend in this etiological profile of optic atrophy. Studies done in 1970 showed intracranial space occupying lesions to be the most common cause, whereas in 1980s, it was found out to be prematurity and hydrocephalus. This is probably due to the advanced investigations and improved medical facilities, which in turn caused increased survival of premature babies. So, aim of my study is to analyze pediatric optic atrophy in terms of etiology and clinical presentation. Methodology, we have done a retrospective review of case records of 40 children who presented to Neuro Ophthalmology department in the span of January 2018 to December 2018, 1 year, and in the age group less than 15 years to Aravind Eye Hospital, Madurai. So inclusion criteria was all pediatric patients less than 15 years age group with diagnosis as optic atrophy, which can be some of them are unilateral or bilateral cases. Patients with economical restraints who cannot get their tests done were excluded from the criteria. Coming to clinical data, age, gender, presenting complaints, systemic conditions, birth history, family history, any prior investigations and treatment were noted. Ocular examination, best corrected visual acuity, pupil examination, anti-segment evaluation, and fundus biomicroscopy was done. Investigations, neuroimaging, CT or MRI, VEP, ERG, and blood investigations were done in appropriate cases. Coming to results, mean age at presentation was 8.3 years in the range of 0 to 15 years age group. Mean visual acuity at presentation was 660. Youngest child age was 1 month. And there were 13 girls and 27 boys in the study. And 8 of them were unilateral cases of optic atrophy and 32 were bilateral cases. Most common presenting complaint was defective vision. And second most common most of them were referred from outside by a pediatrician. And coming to the etiological causes of this optic atrophy, in our study, we found that the hypoxic ischemic encephalopathy was 30%, idiopathic 15%, compressive lesion, congenital, inflammation was 10% each, hydrocephalus was 7%, miscellaneous was 8%, rheumatic 5%, and infection 5%. Conclusion, our study shows that hypoxic ischemic encephalopathy is the most common cause. Children with ocular misalignment or motor disorders present at an earlier age because a child cannot describe the defective vision, but parents notice this misalignment and
1 minute to go.
And it emphasizes the role of ophthalmologists to be aware of prevalent causes so that proper investigations, timely intervention, and appropriate functional rehabilitation can be done. Take-home message, a history in detail should be taken, proper examination, neuroimaging, blood investigation, follow up the patients carefully. There can be recurrence of tumors. Adequate knowledge and prompt diagnosis. Timely intervention, interdisciplinary approach for proper management. These children need utmost care and proper rehabilitation as they also suffer from systemic conditions. And this timely intervention and appropriate rehabilitation also helps in improving the functional potential of these children. Thank you.
Fine.
Free paper number.
Here we are.
Free paper number.
297. 297.
The reason for ischemic encephalopathy in these patients?
The prematurity, sir, and some of them prematurity and infertility, which causes later birth, and
how the child is getting infected. How it's the problem. The child is having a problem because of that.
I mean, like, because born babies, ischem, all brain tissue damage due to the hypoxic. And
how that hypoxia is occurred? Reason for hypoxia?
Forceps delivery in some patients here. And
no, you have not mentioned.
Okay. And many of them were twins, sir. Low birth weight babies with.
Sir.
It's a good presentation. Dr. Durga,
Yes,
how
sir.
did you confirm it is due to hypoxia?
We have taken MRI scans, sir. They were changes of There were changes noted in the MRI and based on prenatal history, natal and postnatal history also confirmed it is hypoxic.
Okay. Previously, that's mainly optic atrophy is due to birth trauma, no?
Yes, sir.
But now we are considering is due to hypoxia. But
Yes.
But for the reason for hypoxia, birth trauma is not producing hypoxia, or is only mechanical
damage? Most of them are like low birth weight, and these so they were twin deliveries. Many.
Okay. Thank you.
Probably she is referring to a poor upcar post delivery. Okay, yes. Stephen.
Doctor, yeah, one more thing. You told 7 cases of hydrocephalus were there.
Yes, sir.
Can you expect papilledema hydrocephalus maybe less than 3 years or more than 3 years? You're telling child.
Less than 3 years.
Okay. And medulloblastoma, you told medulloblastoma usually will cause papilledema, no, rather than optic atrophy.
Yes, papilledema later stages they presented, sir, these cases. So secondary optic atrophy was also considered in the case studies.
Oh, okay. Post papilledema optic atrophy, you're telling.
Optic atrophy was also considered.
So you took all optic atrophies starting from temporal error also, or only the extra primary optic atrophy?
Primary and the papilledema cases also were included, sir. In cases where we cannot do those investigations and we could not find out the etiological cause, they were alone excluded from the studies.
Okay, what about infection or inflammation you told, no? Which infection, brain or optic?
Torch infection patients generally. After this, they had that IgM level investigations, IgM levels and IgG.
Torch infection of what structure? Optic now or brain?
Brain, sir. Congenital rubella syndrome was there in one case.
So torch infection of brain causing retrograde optic atrophy.
Retrograde optic atrophy.
Okay.
What struck me hard with this presentation is that prevalence slide. That slide where you showed the conditions of different conditions and their percentage of occurrence. Idiopathic 15% of idiopathic, that hits us. And we also want to see about comparable studies done elsewhere. The other studies, similar studies which have been done, how much they show hypoxic encephalopathy, because you are showing that as a leader here, 30%. SOL out of the race, I can understand, because SOL now we can pick up fast, locate fast and operate fast. So SOL going on to optic atrophy has reduced over the current 2 decades. That's understandable. But still, hypoxic ischemic encephalopathy seems to be a bit high than to our expectation. It's interesting, doctor. Do the work, compare other presentations with this, and follow it up. Thank you. Thank you.
Thank you, sir.
Yeah. I now invite Dr.Sara Banu, FP288.
Yes, sir.
Yeah, please share your slide. Yeah.
Hello, sir. Whether my screen is visible, sir?
Yeah, it's visible, but it's visible in a funny way. Can you make it a slideshow? Can you make it a slideshow for us? Yeah, the full screen. Yeah, correct. Better. Better. Start, doctor. Yeah.
Good afternoon, everyone. I'm Dr. Sara from Naga Medical College. My presentation is on the assessment of visual acuity and visual outcome of patients with hyphema due to blunt trauma. I would like to to the globe causes anteroposterior compression with simultaneous expansion in the equatorial plane associated with transient but severe increase in the intraocular pressure. Hyphema is a common complication of blunt ocular injury. The source of bleeding, it is contributed by the blood vessels in the root of iris or the ciliary body space. Characteristically, the blood gets settled inferiorly in the anterior chamber, except when the hyphema is total, the blood occupies the entire anterior chamber. The aim of my study is to assess the visual acuity of a patient presenting with hyphema due to blunt ocular injury and the visual outcome following the management of hyphema in them. Material 50 patients of age 10 to 50 years with hyphema due to blunt trauma attending our eye department OPD and residing as inpatients in the ophthalmology ward of GRH Madurai. Detailed history, best corrected visual acuity, slit lamp examination, Goldman applanation tonometry, B-scan biometry, serial visual evoked potential. The visual acuity and the above mentioned investigations during presentation was recorded and serial assessment was done every week for 4 weeks. Such patients were followed up for a period of 3 months. About the observation and analysis, there is increased incidence of ocular trauma among teenage group. That is 46% were less than 20 years of age. The gender distribution, we found that the males are more injured when compared to females. This may be due to the increased outdoor activities among them. The laterality, both the eyes, they were affected equally in our study. About the mode of injury, we found that the predominant mode of injury was due to sports equipment, hand, assault and stationaries. Hence, care must be taken to avoid these mode of injuries. Vision at presentation, 10% of the patients presented with poor vision when the injury was confined to the anterior segment. About the tension distribution, 54% of the patients presented with an intraocular pressure between 11 to 20 millimeter mercury, followed by 28% of the patients with intraocular pressure less than 10 millimeter mercury. Only 18% of the patients they presented with high intraocular pressure. So about the hyphema distribution, 94% of the patients they had grade 1 to grade 3 hyphema. In our study, 12% of the patients they had traumatic mydriasis or sphincter tear associated with hyphema. With the duration of hospital stay in days, in our study, 50% they stayed as inpatients for a period less than 5 days. Only 8% they stayed as inpatients for more than 10 days. Vision during follow-up, 50% of the patients they regained a vision of 6.6 and 28% they regained vision of 6.9 during follow-up. About the complications, in our study involving patients with anterior segment injuries, 96% of the patients did not have any complications during follow-up. 2% of the patients had corneal blood staining and 2% they had angle recession. Gender versus the mode of injury, we found that blunt ocular injuries were more common among males and injuries were mostly due to stationaries, household items and game equipments. So vision comparison after follow-up, 25 patients, they showed improvement in visual acuity to 6.6, 14 patients to 6.9, 5 patients to 6.12, and 4 of them to 6.36, and 2 patients to 6.24. So from the above study, we come to a conclusion that most of the patients presenting with hyphema due to blunt ocular injury affecting the anterior segment of the eye, if treated promptly and in time, can regain better or even normal vision. Thank you.
We are sir. Adipata paralla 98% recover ஆயிருவாங்கங்கறாங்க.
We have examined the posterior segment once hyphema is getting cleared. Have you examined?
Sir?
After the hyphema is getting cleared, did you follow the person and the posterior segment and all?
Sir, initially vitreous hemorrhage posterior segment pathologies were excluded in our studies, sir. After hyphema, we didn't include that in our studies, sir.
No, after have you ever seen? It's not including in all. You have ever seen after hyphema? Once it gets cleared, have you ever seen the fundus? Is there any problem in the macula or macular hole? And it's very commonly no. You can see
Yes,
edema and all started.
Yes, sir, but our patients mostly 50% they improve. They got 6.6 vision, sir. No posterior segment pathologies were there, sir.
50%, 50%.
50% patients they improved to 6.6, sir.
And what about other patients? 50%.
Other patients
6.9 வந்துட்டாங்க.
Sir, 6.9, 6.12.
That's what you said.
Patients.
Why 6.12? You must know that. Why 6.12, 6.24 like that?
So previous refractive errors, we don't know about the before the injury. We don't know about the vision, sir.
What sir wants to highlight, doctor, it's highly unlikely, your profile is highly unlikely. A case which goes for hyphema, frank hyphema, would have had enough injury to produce some Berlin's edema, some follow-up macular hole, some angle recession, some lens subluxation. Something will be there as a lasting injury, causing some poor morbidity over time. We cannot accept that all patients recovered to 6.6 and all patients recovered to 6.9 and only 2 patients went for angle recession. That kind of is bit like probably your study time is less. Probably you follow these patients over time. Probably over time, probably they'll develop. Probably that is one thing which I want to highlight. Sundar sir?
Yes, sir.
Well, one thing, we had one study 91 or 92 in our RIO. That time only subconjugal hemorrhage got improved. After a week, you saw Berlin setting. So externally, it was very simple, but actually, patient had visual problems.
Yes, sir. Yeah. Dr. Sara, whether you are comparing the vision, it's because of hyphema or because of blunt trauma, mechanical injury. Whether
because of
visual
hyphema,
defect
sir.
is due to hyphema only, or visual defect is due to some other factor.
So we are comparing here the vision defect due to hyphema, sir.
Only with hyphema, not with other causes. Suppose
No,
mechanical injury producing like optic atrophy or something.
No, sir. Here, only due to hyphema, sir.
Okay. With the hyphema, we are correlated with the vision.
Yes, sir.
That means, okay. So if it is severe hyphema only, that vision is little less. Otherwise, it's all right, no?
Yes, sir.
Yeah. Okay. Thank you.
Thank you, sir.
Stephen?
Dr. Sara, one more important thing.
Sir?
How much percentage of your case had total hyphema or more than 3/4 in the third grade? How many patients? Yeah.
6% they had grade 4 hyphema, sir.
So grade
94% they had grade 1 to grade 3 hyphema, sir.
Okay. In that 6% of the total hyphema grade 4, any other in that 6% what you told, no, grade 4?
Sir?
Yeah, in the 6% of that grade 4 hyphema.
Sir?
Yeah, can you hear me now?
I can hear, sir.
Yeah, in the 6% of this grade 4 hyphema, no? What are the other ocular anomalies? You told about angle recession and corneal blood staining. Yeah, these two are there. In which grade of hyphema? That's what I want to know.
So, in grade 4 hyphema only, sir.
That you didn't mention in your study, you told, huh?
No, sir. Sorry, sir.
Yeah,
I didn't mention it.
That's very, very important, no? So
Okay,
all
sir.
these two anterior segment complications you mentioned was there in grade 4 hyphema.
Yes, sir.
Okay. Okay.
Drag it on, Doctor. Model the study as a long-term study, and probably I think the end vision which you are referring to is at time of discharge. Probably you admit the patient stays with you for a week or 10 days, and at discharge you are taking the vision.
Sir, end vision is after 3 months of follow-up, sir.
Oh, very unlikely. We are surprised at your study result, and compare with the comparable studies which are done elsewhere, and see how different your profile will be from their profile.
Okay, sir.
Okay. Thank you.
Sir. Thank you, sir.
Thank you. May I invite now Dr. Shobana Priya, free paper 414.
Sir, good morning, sir.
Morning. Share, doctor.
Can you able to see my slides, sir?
Yes.
Full screen, right?
Yes, sir.
Then probably you'll need to change your cell phone into the portrait mode.
Okay, sir.
Into the landscape. Yeah. Correct.
Yes, sir.
Correct. Better.
Shall I start, sir?
Yeah, please.
Good morning, everyone. I am Dr. Shobana, third year postgraduate. My study title is a study of in situ conjunctival tissue with autologous blood as primary procedure for pterygium excision. So pterygium is a fibrovascular ocular growth encroaching into the cornea, pathology being ultraviolet rays induced allostatic degeneration, causing ocular discomfort and decreased visual acuity. Grading include grade 1 crossing limbus, grade 2 midway between limbus and pupil, grade 3 reaching up to pupillary margin, grade 4 crossing pupillary margin. Treatment includes surgical removal remains the main treatment. The main procedure is complete pterygium excision, leaving the bare sclera, which has a relapse rate of 24 to 89%, warranting an adjuvant method. There are various methods, but what we adapted is conjunctival tissue graft from the pterygium site itself using autologous blood as a bioadhesive. So the aim of the study is to analyze the method of pterygium excision with conjunctival autograft from pterygium site using autologous blood clot. Materials include a case record of 30 eyes of 30 patients were included in the study. Data from July 2018 to July 2019 were analyzed retrospectively. Data collected include patient's age, sex, ocular history, medical history, surgical techniques, and complication. In the study, grade 2 and grade 3 pterygium were included. The study was approved by Institutional Ethical Committee. Moving on to the procedure, under strict aseptic precaution under local anesthesia, about 1 cc of normal saline was injected subconjunctivally into the pterygium tissue. Thin layer of conjunctival graft was patiened and separated completely from the pterygium tissue. After excising the pterygium using autologous blood, thin conjunctival layer was applied over the bare sclera. It is spread and held in position for 5 minutes until firm setting of the autologous fibrin occurred, ensuring graft adhesion. Antibiotic eye drops and a pressure bandage was applied. Routine post-operative therapy was given. Patients were followed up on first post-operative day, first week, first month, third month, and 6th month. At each visit, graft adherence, displacement, retraction, and recurrence were assessed. So moving on to the results, in our retrospective analysis, 30 eyes of primary pterygium were assessed. A mean age of the patient being 45 plus or minus 12 years. Out of 30, 17 being male and 13 being female. 2 had graft loss, 1 had graft retraction, and 3 had graft edema. And 80% of the patients had a good recovery and outcome. The operating time was 15 minutes, and there was no single case of pterygium recurrence after 6 months of surgery. Moving on to the discussion, a variety of surgical techniques have been proposed with recurrence prevention as the main aim. The major complication of pterygium is recurrence, graft retraction, and suture-related complication. With this operative procedure, we aim to use same-site conjunctival tissue, sparing the superior conjunctiva for future use and to minimize the suture-related complication and recurrence. The use of patient's own autologous blood was based on the mechanism of blood coagulation and fibrinolysis.
1 more minute.
Kodavar SK et al. In their study state concomitant use of conjunctival graft from the primary pterygium itself to cover the bare scleral defect with fibrin glue. But instead of fibrin glue, we due to cost factor, we used autologous blood clot. In the study, graft edema could be due to excessive handling of grafts and subsided with 1 week post-operative steroid. Graft retraction is due to inclusion of tenons in the graft and can be overcome by meticulous dissection. Usually, pterygium recur within 6 months. In our study, there was no recurrence observed. To conclude, this study is an effective procedure for patients with primary pterygium, and it is more economical, prevents the suture-related complication, and reduce the recurrence rate, spare superior conjunctiva for future need. These are my reference, and thank you, sir.
Okay, sir.
Nice presentation. Thank you.
Okay, sir.
Sundar sir.
Yes, sir. Dr. Shobana, it's a good presentation.
Thank you, sir.
But you have taken conjunctiva from the pterygium tissue itself, no?
Yes, sir.
Whether that conjunctiva is totally cut down or that base of the conjunctiva still is intact with that tissue itself?
Sir, it's underlying pterygium is cut off.
Is removed. Yes, superficial conjunctiva is
a thin layer of superficial conjunctiva is spared. Yes, sir.
Okay, so the base is attached. Only the tip and other things have been removed.
Yeah.
No?
Yes, sir.
Okay,
yes, sir.
So with that only you use the autologous serum. Okay.
Yes, sir.
Anyway, it's a good study. Good, thank you.
Thank you, sir.
Yeah, Dr. Shobana.
Yes, sir.
It is a very good procedure. As Sundar sir asked, I'm having a doubt. You cut the conjunctiva at 4 sides is cut and then stuck like an autograft, or only 3 sides are cut. Still, I am not clear on that.
Well, 3 sides are cut, sir. At the medial end, it will be attached, sir.
Medial end, it is continuous with the parent tissue.
Yes, sir.
Yeah, the remaining superior, inferior, and the corneal side is
limbus side is cut.
Limbus side is cut, and then it's retracted, and then it is stuck on with the fibrin glue.
Yes.
Okay. So any stem cell regarding stem cell? Anything about this in this procedure? Stem cells are still there.
Limbal stem cells only there, sir. Actually, limbal stem cell act as a barrier. But in recent studies, it is said that this limbal orientation need not necessary to avoid recurrence, sir. So there won't be any limbal stem cells, sir.
Yeah, why I'm asking is because you are attaching the corneal side of the conjunctival tissue with the limbus. Not the limbus part is going back.
Yes, sir. We are not rotating.
That's what I'm asking. Yes. That's what I'm asking, because you're keeping the conjunctiva near the apex of the conjunctival side. No, that is attached to the limbus, not actually the limbal part of the conjunctiva is in the limbus.
No.
Is that a case, or you trim that apex part and attach the limbus part with the limbus?
No, sir. We are not giving limbal orientation, sir.
Okay. It's just retraction and then applying the
fibrin
tissue glue.
autologous blood, sir.
Okay.
By default, there will be limbal orientation. No, towards the medial side you are keeping, and the flap you are resetting on the clotted blood. So by default, it will again go and fall back as if it is as before. And the logic of a limbal autograft is to spare the, as Stephen pointed out, the logic of limbal autograft is to spare the stem cells from one area to another area so that these degenerated cells get populated by that fresh cells and the pterygium doesn't recur. So your procedure seems to be a bit away from that logic of how we accepted limbal stem cells. So please follow up. The 6-month follow-up is a short follow-up. Please do it for a period of time and see whether we'll be happy if you don't have recurrence, but we'll surely believe that you'll have some recurrences in this. And if it doesn't, then it sort of we'll have to study it more and see comparable studies done elsewhere and try to adopt this as a good procedure. Thank you, doctor.
Sir.
Wonderful.
Thank you.
Nice.
Thank you, sir.
The next presentation is Dr. Karthik Kumar, FP500. Karthik is here?
Yes, sir.
Yeah, please.
Sir, the previous speaker should stop sharing the screen.
Yeah. Shobana, stop sharing the screen.
Yes.
Yeah, now it's yours.
Good afternoon, sir.
Your slides are not.
Host your screen first, sir, so that you can start speaking. Because it's just 4 minutes now. We start the timer from the time you host the screen.
Sir, able to see the screen, sir?
Not yet.
You share
Not
it.
yet.
And share. Share that new share.
Dear green. Okay.
Yeah, you're doing it. Correct. Full screen vachidunga mudigal.
Yes.
Yeah, fine. Starts. Your time starts now.
I'm presenting a retrospective study on ethambutol induced optic neuropathy. Ethambutol is a part of treatment protocol for tuberculosis since the 1960s, causing well-defined dose-related toxicity. It chelates zinc, which is an important factor in nerve function. It causes profound and sometimes permanent vision loss, so early diagnosis and replacement with alternate drug is important. It causes central or peripheral field loss with or without dyschromatopsia. At a dose of under 15 mg per kg per day, toxicity is unlikely to develop, but at doses of 15 to 25 mg per kg per day, visual symptoms may develop over a period of months. Some visual improvement may occur with the discontinuation of the drug. Still, some visual field and contrast sensitivity abnormalities may persist. According to RNTCP, in old regimen, patients are receiving ethambutol only for 2 months, that to 3 days a week. According to new guidelines, patients are receiving daily ethambutol for 6 months. So aim of our study was to evaluate visual decline in patients with ethambutol optic neuropathy and visual recovery after cessation of ethambutol, and to correlate changes in amplitude and latency of pattern VP with visual recovery. We did a retrospective observational study of 30 consecutive patients with ethambutol optic neuropathy at Aravind Eye Hospital, Coimbatore between July 19 and October 19. We included patients above 18 years of age on ATT, including ethambutol, and patients with any optic nerve pathology were excluded. Visual acuity, color vision, contrast sensitivity, and central fields by germ screen were done in all visits. VEP were recorded at the time of presentation. Once EON was diagnosed, after discussing with the treating physician, ethambutol was stopped and replaced with levofloxacin. Results: we had 18 men and 12 women with a mean age of 54 years. All were on ethambutol for a median period of 6 months. The average interval from onset of vision loss to stopping ethambutol was 4.4 weeks. Mean visual acuity of all patients at presentation was 612, which improved to 612 at 3 months follow-up. And patients who took 4 or more weeks to stop ethambutol after initial visual decline presented with a vision of 636, which improved to 615 at 3 months follow-up. Who stopped less than 4 weeks after initial visual decline presented with 618 vision, which improved to 69 in follow-up. So the presenting vision for patients who stopped greater than 4 weeks was statistically significantly worse than patients who stopped before 4 weeks. So VEP changes, more than 4 weeks group had an amplitude of 1.4 microvolt, whereas less than 4 weeks group had an amplitude of 2.4 microvolt. and the difference was statistically significant, and it was consistent with the visual acuity differences between these two groups. The latencies were normal and without statistically significant difference between the groups. It was also observed that patients who presented with normal or hyperemic disc had good visual
1 minute to go.
patients who presented with temporal pallor or pale disc. So the toxicity is dose related, and current regimen recommended dose of 15 to 25 milligram per kg per day. So patients who took longer to stop ethambutol presented with worse vision than patients who stopped it sooner. So these findings support prompt cessation of ethambutol after presumed optic neuropathy to prevent visual decline. These findings are consistent with other reports of visual decline in ethambutol toxicity. An important finding of our study was that worse the vision at presentation, worse was the final outcome. All patients had reduced VEP amplitudes in our study. Unfortunately, we do not have VEP results after visual improvement to demonstrate changes after cessation of ethambutol. There were no significant changes in latency from the normal population in any group, which is consistent with a non-demyelinating optic neuropathy. To conclude, the interval from vision loss to stopping ethambutol is an important marker for visual recovery. VEP amplitudes were consistently reduced in our series of patients, but there was no change in latency. Small sample size and lack of VEP results after visual improvement limitations. Future studies could include correlation with OCT and visual field analysis. Thank you.
Okay.
So, you have not done any visual fields, no, nothing.
Sir,
he has only gone by VEP. He hasn't even done color vision, I think. No color vision,
we did
no,
color vision,
no
sir.
field. You did? Okay.
But you have not mentioned. You have not mentioned about the color vision or something like that. You just told the visual acuity. What about contrast? Nothing you have mentioned.
Sir, we did visual acuity, color vision, contrast sensitivity, and
central
fields was screens.
The diagnostic criteria you could have mentioned in one of your slides. You could have told us, oh, these are the ones. Okay. 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 Of the patients who had decreased amplitude, were both the eyes comparable?
Yes, sir. Yes. Almost both were symmetric, sir.
So if a person has ON optic neuritis due to ethambutol, both his eyes had comparable suppression of VEP amplitude.
Yes, sir. Yes, sir.
Okay. Okay.
What levofloxacin?
Yes, sir.
Started giving after you suppose you suspect ethambutol optic neuropathy.
Yes, sir. Once ethambutol was stopped, they were started on levofloxacin.
Who started? Physician or yourself?
No, sir. Physician started, sir.
What is the logic?
Sir?
What is the logic that starting levofloxacin once stopped ethambutol?
So the physicians, like, they needed to replace another drug, sir.
They have other 4 drugs. ATT is 4 drugs. Why they suddenly bring in levofloxacin? I'll just find out.
Sir, most of them were in the continuation phase, sir, where they were taking isoniazid, rifampicin, and ethambutol. So for the third drug, they were replacing it with levofloxacin, sir.
Okay. Okay. And how was the recovery? Yes, sir. Yes, sir.
Sir, levofloxacin is a what to say? It's a spare drug. So any patients having any multi-drug resistance.
Oh, one of the drugs. Okay.
Spare drug. It's a spare drug, sir.
It's a fifth drug. Okay.
Substitute, sir.
Yeah. Even in HIV-related TB, they use it. Correct. Yes, Stephen. Any questions, Stephen?
Dr. Karthik, one important doubt.
Yes, sir.
Your study included the patients presenting only with vision loss, not all patients on ethambutol, no?
No, sir. Only with vision loss, sir.
So the main hero in your study is the patient should tell he is having defective vision, correct or not?
Yes, sir.
Then only you will include him as ethambutol-induced optic neuropathy and do all the investigations and find out less than 4 weeks how much it is. After 4 weeks, how it behaves. So according to you, less than 4 weeks, the patient told after vision loss, good prognosis. More than 4 weeks, the patient told after vision loss, other things, recovery and amplitude, everything reduced. So it's a good observation. And
sir.
So did you do you told the median duration of this presentation 6 months after the ATD was started, no? So
yes.
It took so long for the ethambutol to cause toxicity, or what was the least duration and what was the highest duration of the toxic patient?
So least duration patients were like 3 or 4 months, sir.
Oh, least is only from 3 or 4 months, according to your study.
Yes, sir.
So 3 months after taking ethambutol only, patient first had defective vision.
Yes, sir.
The highest duration
Sir,
was?
few patients like TB spine, they were taking for 2 years, sir. That is why median period like it came around 6 months, sir.
Yeah, that's what, because most of the treatment schedule is only around 6 months.
6 months.
In your study, you're telling 6 months means it gives a false opinion that after only taking 6 months of ethambutol only patient will have this problem. Because since you included this 2 years also, the median study went very long.
Yes,
so
sir.
that gives a false this one. I think you have to correct on that. So you need not mention about the median study, because the study, the total duration of treatment in TB is only around 6 months.
Yes, sir.
So by the time ethambutol toxicity develops, the patient would have completed the course of TB treatment. No, so that point I think it's a wrong message that you could have avoided, because it's correct only, but statistically it is correct, but clinically if you take 6 months is a total duration of therapy for tuberculosis.
Yeah.
So the least time was 3 months.
Yeah. Yes, sir.
Okay.
Sundar sir.
Yes, sir. Okay, no questions. No,
yeah, fine. Thank you, doctor.
Thank you.
So we complete the list, sir.
One more.
One more candidate is there?
Dr. Gayathri.
Gayathri.
Yes, sir.
Oh, sorry. 571, FP571, Dr. Gayathri Devi. Yeah, I saw it. Gayathri, you're here?
Dr. Gayathri, share your screen.
Sir, shall I present, sir?
Yes,
yeah, please share your screen first.
Gayathri with video.
You haven't started sharing your screen, doctor. Go into that share screen option. Yeah, please. And make it into a landscape mode. Yeah, correct.
You have come back. Yeah, I'll share again.
Okay. She's trying something, I think.
That's it, visible, sir.
Correct. PowerPoint. Slideshow. Yes, doctor. Yes.
My topic is on a clinical evaluation of optic neuropathy in various etiologies. Introduction. Optic neuropathy occurs due to various causes, but there is no uniform availability of reliable data on optic neuropathy. Most of the studies concentrate on the individual etiologies only. So in this study, the clinical electrophysiological imaging profile of optic neuropathy of various etiologies was studied along with the age and sex distribution. Aim of the study is to determine the clinical profile of patients diagnosed with optic neuropathy and to evaluate its etiology. So materials and methods, a total of 83 cases of optic neuropathy were included in the study, and the following investigations were done in all the cases, and specific investigations were done according to the suspected etiologies. Inclusion criteria, all clinically proven cases of optic neuropathy, that is decrease in the visual acuity, abnormal pupillary reflex, and dyschromatopsia and visual field defect were were included in this study. And exclusion criteria, patients with visual symptoms due to other causes like glaucoma, uveitis were excluded, and in whom the proper visual assessment cannot be done were excluded. Optic nerve involvement along with other cranial nerve involvement were excluded in this study, and congenital optic disc anomalies were excluded. Results and discussion. Most common etiology observed was idiopathic, 37% of cases, and next to that ischemic optic neuropathy and traumatic optic neuropathy. Age and sex distribution. Most commonly affected age group was between 31 to 40 years. Males were slightly more commonly affected than females. Unilaterality is more common than bilaterality. Blurred disc margin was the most common fundus finding observed. Visual field defects. Most common visual field defect observed was central or paracentral scotoma. And prolonged P100 latency was the most common VEP finding observed in this study. And radiological finding, normal brain imaging was found in more than 50% of cases, demyelination in 10%, and optic nerve signal abnormalities were seen in 13% of cases. Best corrected visual acuity on presentation is 5/60 to 3/60 in 33% of cases, and out of 83 cases, follow-up can be done for 3 months in 55 cases. At the end of 3 months, the 28% of patients were between 6/24 to 6/60 vision. Conclusion. Optic neuropathy is essentially a clinical diagnosis
detailed history and examination refine the differential diagnosis. The patients with atypical clinical features needs further investigations to rule out the etiologies like tumors and autoimmune disorders. Compared to the Western studies, in my study, traumatic and ischemic optic neuropathy prevalence is higher, and demyelination optic neuritis is low. Thank you.
Okay. Sir, here we are.
No questions. Okay.
Sundar sir.
Yes, sir. It's a good observation, but still demyelinating disease is higher prevalence in some of the places. I don't know how they are ruling out it's not a demyelination and other things. But still we say as an idiopathic, whether we are not able to confirm the diagnosis, because of that we put it as idiopathic. So whether it comes under demyelination or some other category, still we don't know. But anyway, it's good observation, sir. Thank you.
Stephen?
Dr. Gayathri, with regards to this idiopathic etiology, no? It's idiopathic optic neuritis or idiopathic optic neuropathy?
Optic neuropathy, sir.
No. What was the fundus findings? Optic disc findings in these idiopathic cases? Whether it was edema or pallor or
all pale disc also there, sir, and retroverbal optic or normal optic disc also there, sir.
So there were normal optic disc, there were pale optic disc.
Yes, sir.
And there was optic blood also was there. All three were there.
Three were in
idiopathic group.
Yes, sir.
So I think your study would have been even more better if in idiopathic itself you should have mentioned what was the finding in the optic nerve. That's very, very important because you're almost 30% of your cases are idiopathic. So you should mention what type of optic disc findings was there in this idiopathic, so that we can find out the idiopathic cause. Because for blurring of disc margin, there are several other viral infection, bacterial infection, so many things are there which you routinely won't do. For pallor, there may be some lead poisoning or vitamin deficiency can be there, which you should do then serum to find out. And a normal optic disc, as you told, it can be, that is okay. That can be found out by imaging or retrobulbar neuritis. But the remaining two, no, you have to find out other causes in blood or infectious serology to find out the idiopathic cause. So that would have been even more better if you were stressed on the type of the disc findings in these idiopathic cases, so that you can order more investigation and try to find out the cause before labeling it as idiopathic. Sir, sir, any observation on this, sir?
I don't find nothing wrong.
What I was feeling is like, as Sundar sir pointed out, more temperate and cold climates demyelinating, more in our tropical places the others. That is also at least acceptable. But I think the more interesting part of the studies would have been to see how these people responded to methylprednisolone. I'm sure you would have used methylprednisolone as a strong option in all these cases. And across the etiological factors, how did they behave? Did these behave better than the other ones? Would have been an illuminating point. So probably you'll have to extend your study, you'll have to continue your study and try to look at it from the management angle also, doctor.
Yes, sir.
Congratulations. Thank you.
Thank you, sir. Thank you, sir.
Thank you. So we have completed, sir. PRV sir, உங்க closing remarks. ஒரு ஜோக் அடிங்க பார்க்கலாம், எல்லாரும் சிரிச்சிட்டு முடிச்சு.
Only problem I have seen, no, nobody is showing the face of them.
உங்களை பார்த்தா பயம், அதனால.
Gayathri Devi, come on out, come out. I have seen you yesterday. Hello.
Yes, sir. Yes, sir.
Come out and show your face.
Sir. Yes, sir.
Yeah. All PGs can come. I think they can enter the screen if they are there. So we'll finish. I think the marking and the selection would have been done already, no, simultaneously. We don't need to spare time on that. Okay.
The judges, once they enter in the Google Sheet and press submit, it
would have already been
received in the Numerotech team.
Yeah.
They will consolidate and they will give, and results will be announced at 3:30, sir.
Yeah. Okay. But what I am very happy is comprehensive ophthalmology is never boring. That is one central point about comprehensive ophthalmology. Illana or retina session la sir, 7 presentation 7 me OCT da. OCT for breakfast, lunch, dinner mari.
Teachers, great teachers like you, it will not be boring, sir. It was very All of you were very interactive
and if you see the content also, it was spread across, and it was very like something which affects us day to day. Tomorrow morning in the OP, you can see one of these cases. So these sessions give you some take-home points which will help you to see those cases better. I sincerely thank from the bottom of my heart Dr. V.R. Vijayaraghavan sir, Dr. Sundar sir, and Dr. Stephen, and Dr. Pratibha for being all in charge of this session and pulling us together at this odd hour of 1:40 and making us stay through 2:40. And I thank the TNOA office bearers and MCOA office bearers, and especially Dr. Atik and Dr. Ravishankar for having done all the homework, paid work for doing this session. And across, I think all the postgraduates, I have heard feedback from my postgraduates. All postgraduates are very happy because they have got this capacity to present as posters or papers in this session and be judged by these honorable judges, and that it's a big learning experience for them. And at least we fought against COVID and not missed this opportunity of a learning experience for our postgraduates. Thanks one and all. It's a wonderful session. I think we'll close down with this. Thank you.
Thank you. Thank you.
I want to know whether it's a poster or free paper, because when I submit, it's coming as evaluation of posters.
No, this is free paper.
Ella FP da sir.
Free paper.
Probably FP na da adukkum login avudunu nenikren. I think
sir,
posters
they have put posters.
Evaluation is already done.
That is e-posters.
Okay.
E-poster evaluation is already done. Only papers are there, sir.
Okay. Thank you for your valuable time for evaluating papers. That is what
நீங்க ஏதா பட்டனை மாத்தி எழுதிட்டீங்க.
எனக்கு மந்திரில
சந்தோஷம் சார். Thank you sir.
Thank you sir. Thank you.
Thank you.
Thank you very much sir.
Thank you Pratibha.
Bye Stephen.
Thank you sir. Thank you sir.
Thank you.
Bye.
Bye sir. Bye. Bye.